Okay, good evening, surgeons. I'm Dr. Maheshwar Naidu. We're doing a live stream broadcast this evening on endoscopic intervention in the upper GIT. Um, please give me some feedback via WhatsApp. There's a WhatsApp group, or you can WhatsApp me directly. If there's any issues with the picture or the sound, please let me know. I can try and correct it straight away. The topic for this evening is endoscopic intervention in the upper GIT. I'm just going to wait 2 minutes to give people time to join in. Okay, let's get started. Got a bit of information today, and just a summary of what we're going to be looking at today. Going to show you some interventional or operative videos on esophageal dilatation, that's endoscopic, and stenting for benign and malignant strictures. Then we're going to look at endoscopic treatment of bleeding peptic ulcers, endoscopic treatment of bleeding esophageal varices, removal of foreign bodies in the upper GIT, POEN, which is an abbreviation for per oral, endoscopic myotomy for achalasia, as well as corrosive injury of the upper GIT. I am not sure if we're going to get through all of these videos. The actual videos are quite detailed and long. So we may have to spread today's lecture over 2 sessions, this week and next week. Just to remind you that we have actually done operative or open surgical procedures in the upper GIT last year. This was done on the 4th of July 2018. So if you have access to teachable.com, and if you don't have access, please let me know. All of the registrars in the surgery registrar group have been given access. We did at that stage cover briefly endoscopic esophageal procedures, but that section up here I'm going to cover in more detail today. But what was well covered in the lecture in July last year was Heller's myotomy, laparoscopic Heller's myotomy, esophageal pouches, Zenkas and lower esophageal pouches, fundoplication, as well as esophageal substitutes, that's esophageal replacement with either jejunum, gastric block, or colon. So today's lecture we're going to be looking at these topics in more detail, and let's then proceed to esophageal dilatation and stenting. This is very extensively used in South Africa because unfortunately we do not have a proper screening program for esophageal cancer, and we also have a fair number of patients that present with benign strictures from, for example, reflux, and the other common cause is caustic ingestion. So it's very important to have an understanding of this. Not everyone has the opportunity to pass through a specialized upper GI unit, and even if you do, as a registrar, you may not get to actually do any of this yourself or see it. So this is why I want to actually do these videos to give you some understanding of what actually takes place. Okay, the first video clip is a brief 5-minute video. It's actually from a company that is promoting their product, but nonetheless it gives a good indication of the different types of stents.
The stent should extend beyond the edges of the strictures by at least 2 centimeters. The delivery sheath is unlocked and slowly withdrawn while maintaining stent position. The delivery system and guide wire can be removed at this point. If the degree of stent expansion needs to be assessed more accurately, this can be done by further injection of contrast or endoscopically. However, care needs to be taken not to displace the stent by advancing the endoscope through it. Nitinol stents reach their full radial force only after warming to body temperature and will continue to expand for several days. Balloon dilation should be avoided. Your local S&G Biotech representative will be more than happy to answer any questions.
Okay, that's quite a commercial video, but it does actually explain the stents quite nicely. As far as I know, we don't actually have this company in South Africa, S&G Biotech. The typical stents that I have seen are Boston Scientific, and they are usually covered by a silk thread. And what happens is that instead of withdrawing a catheter over the or from the stent, you actually pull the thread and it unwinds and releases, and then you get proximal release and distal release. If you do have a specialized upper GI unit in the unit that you're working on, you can visit one. Please do go there, and you can actually just speak to the nursing staff in the GI unit and ask them to show you these products. They will not obviously be able to deploy them because each one of these costs about 6,000 to 8,000 rand, but they actually work exceedingly well. If there's any questions, please submit them via WhatsApp. Okay, this is a more detailed video that actually discusses placement, complications, tips and tricks. I'm just going to run that now.
Esophageal stents are commonly utilized for a variety of purposes and in modern clinical practice. The most common indications for the treatment of malignant dysphagia, stents can be placed in preoperative and non-operative candidates. Other indications include the treatment of benign esophageal strictures, fistulas, and leaks. The representative stent deployment will now be shown, focusing on the endoscopic view. The patient in this case has a very proximal esophageal cancer. There is complete obstruction of the esophagus, and the endoscope cannot pass into the distal esophagus or the stomach. The guide wire in this case, a straight biliary guide wire through a straight biliary catheter, is advanced through the tumor, and access is obtained to the distal esophagus and stomach. The stent is then advanced over the wire and deployed. Because the tumor is very proximal in this patient, an effort is made to overlap the proximal end of the stent to the very proximal end of the tumor as much as possible. After stent deployment, the delivery catheter and associated guide wire can be removed from the patient. The stent can then be inspected for position, patency, and signs of any immediate complications. You can see the stent is in excellent position. Tumor is visible through the stent entrance. The stent is widely patent. Representative stent deployment will now be shown, emphasizing the fluoroscopic view. In this patient, the endoscope could be advanced through the tumor to the distal portion of the mass into the gastric cardia. This position is marked endoscopically with an image. The endoscope is then withdrawn to the proximal aspect of the tumor, and an image is also obtained. Thus, the distal and the proximal end of the stricture are then clearly marked. A wire, in this case a savory wire, is advanced through the tumour and into the stomach, and the endoscope is removed over the wire. The stent, in this case a fully covered stent, is advanced across the stricture, the distalmost portion of the stent, below the bottom of the tumour. Final adjustments are made, deployment is allowed to commence. In this patient, the stent is deployed in a distal proximal manner, as is most commonly performed. The stent is fully deployed, clearly bridging the entire tumour. The delivery catheter and its guide wire are then removed from the patient, and the stent is left in place, bridging the entire tumour. Endoscopic inspection following deployment usually reveals a fully deployed and well-placed stent. Here you see a fully covered stent in good position across a tumour. Tumour is visible through the stent. Through and through endoscopic evaluation of the stent is not required post-deployment, but can be performed if desired. Here you see a retroflex view of a distal stent. Endoscope is then straightened and removed through the stent. Distal portion of the stent is in good position in the gastric cardia. The stent is patent without signs of complication or other difficulties, and the proximal end of the stent is above the proximal end of the tumour. If clinically indicated, a stent can be placed in the very proximal esophagus. This requires very precise placement by the endoscopist. Here you see a fully covered stent placed immediately below the upper esophageal sphincter and a patient with a very proximal cancer. This patient tolerated the stent well. Complications can occur. In this case, you see an infolded stent immediately after deployment. Infolding can occur due to poor placement, incorrect stent size, or may be a sign of a non-compliant tumour. The stent can be left in place, removed, or manually adjusted to allow complete expansion. Stent placement can be adjusted following deployment as needed. A rat tooth forceps allows for rapid and efficient stent adjustment in most cases. This video shows the use of a rat tooth forceps to proximally adjust the position to fully cover an esophageal stent. The stent is moved approximately for a distance of 2 centimeters. When the stent is felt to be in adequate position, the rat tooth forceps release the stent and the position can be directly assessed endoscopically. If satisfactory, no other adjustment is required. Some stent migrations are associated with recurrent dysphagia and warrant stent replacement. At other times, stent migration is a sign of response to neoadjuvant therapy. Stent migration is unfortunately a common development following deployment, especially with fully covered stents. Most migrations can be managed endoscopically. This video illustrates complete migration of an esophageal stent into the gastric cardia. The stent is grasped by rat tooth forceps around the proximal retrieval string if possible. The stent is then withdrawn through the tumour and the esophagus with the rat tooth forceps. Note here that when the endoscope is removed from the patient, the stent has come off the rat tooth forceps. The rat tooth forceps have been withdrawn back into the endoscope and the patient is reintubated. The stent is located just below the level of upper esophageal sphincter. The endoscope passes into the proximal esophagus. The stent is grasped, again with the rat tooth forceps, by the retrieval string and removed from the patient. Other complications, including tumour ingrowth and overgrowth, can be treated by stent within stent placement. Perforations are rare, but can often be managed by other stent placements.
Okay, that is quite a neat video. We've done now with dilatation and stenting. I'm going to look at upper GI foreign bodies, which is quite a common occurrence. And there are a variety of methods of actually removing these foreign bodies, and we shall take a look at a couple of videos of that.
In adults, accidental foreign bodies (FB) ingestion tends to be food bolus. Non-food object ingestions occur more in denture users, psychiatric patients, incarcerated individuals, and alcohol-intoxicated patients. The majority of the ingested FB will pass spontaneously. With therapeutic endoscopy, fewer patients require surgical intervention. Mortality rates are extremely low. Commonly used foreign body retrieval devices include net retriever, snare, basket, rat tooth, shark tooth, and rat tooth alligator jaw, grasper, and pronged grasper. This is net retriever grasping device and pronged grasping device. For a sharp or pointed foreign body, these common mucosa and airway protection devices can be used: foreign body hood protector, banding device cap, friction fit cap, anoscope, and endoscopic overtube. We are fitting a foreign body hood protector. As the endoscope is withdrawn through a narrow segment, usually at the level of a sphincter, the FB hood protector flips over the grasped foreign body, providing mucosal protection against the moving foreign body. The banding device cap is another inexpensive and versatile device for removing sharp and pointed objects. An endoscopic overtube consists of an outer tube and a proximal obturator. Prior to overtube insertion, the proximal obturator should be pre-inserted inside the overtube, and both devices are gently advanced over the inserted endoscope. This will minimize the risk of perforation and mucosal injury. In cases of a pointed foreign body, hood protector, banding device cap, and anoscope can be used for anal canal protection. Once through the esophagus, most FB, including sharp objects, pass uneventfully. Risk factors for perforation include sharp or pointed foreign body, animal or fish bones, and magnets. Imaging studies aid in non-food FB localization and medical documentation. Biplane radiographs identify most non-food FB. In cases of suspected food bolus impaction, a contrast swallow study is generally not recommended because of aspiration risk. Emergent endoscopy should be performed in patients with esophageal obstruction with inability to swallow secretions and with disc batteries and a sharp-pointed foreign body in the esophagus. For food bolus impaction in the esophagus, a combination of piecemeal bolus removal and gentle pushing at the center of the bolus is usually successful and safe. proteolytic enzyme should never be applied. This patient presented with food bolus impaction with inability to swallow secretions. Using an endoscopic net retriever, the food bolus is removed piecemeal. The tip of the net retriever is placed between the food bolus and the esophageal wall with an open net to capture the top portion of the food bolus. After piecemeal removal, the food bolus can usually be successfully dislodged with gentle pushing at the center of the bolus. The underlying pathology is esophageal inlet segment with associated stricture. This patient inadvertently swallowed a denture, and it is impacted within the upper esophagus. He cannot swallow saliva. Emergent endoscopy is performed. The denture is impacted within the esophageal introitus. Attempts should not be made to push down a sharp and impacted object. In this case, we are using an endoscopic grasper to capsule the impacted denture and gently disimpact the object. With a slow pulling force and fine twisting of the endoscope, the impacted denture is removed without event. Endoscopic examination of the upper esophagus and esophageal introitus reveals several ischemic ulcerations from the impacted denture. Once the foreign body is in the stomach, it usually passes in several days. Conservative management is appropriate for most asymptomatic gastric FB. However, endoscopic removal is indicated for sharp FB, FB greater than 6 cm in length, greater than 2.5 cm in diameter, and FB retention in the stomach greater than 3 to 4 weeks. In this case, an intentionally swallowed razor blade is removed endoscopically. Once a foreign body enters the small bowel and is beyond the reach of conventional endoscopy, daily radiographs are needed for sharp pointed FB to ensure its safe passage. This patient unintentionally swallowed a needle, and it has migrated into the proximal small bowel. During push enteroscopy, the needle is seen within the proximal jejunum. The pointed tip of the needle is captured with an endoscopic snare. Once the needle is pulled inside the stomach, a banding device cap is used to assist needle removal through the esophagus and larynx. In this patient, a retained capsule endoscope is inside the small bowel. During push enteroscopy, the capsule is seen trapped inside a small bowel diverticulum. With gentle manipulation, the capsule endoscope is captured with an endoscopic snare. Once the capsule endoscope is pulled into the stomach, an endoscopic net retriever is used to capture the capsule and remove the capsule through the esophagus. A 28-year-old male unintentionally swallowed a razor blade and he was asymptomatic. In the emergency room on KUB, the razor blade can be seen in the left upper quadrant. Emergent upper endoscopy failed to localize the razor blade in the stomach and duodenum. On day 3, the razor blade has migrated into the right lower quadrant and into the descending colon in the afternoon. In order to avoid injury within the anal canal or the anal sphincter during spontaneous passage of the razor blade, an unprepped sigmoidoscopy is performed. The razor blade is grasped with an endoscopic grasper. The razor blade is then dropped into the rectal vault. An endoscopic foreign body hood protector was placed on the tip of the endoscope. The razor blade is then removed through the deployed endoscopic hood without causing anal canal injury. Rectal FB are either ingested or inserted through the anus. FB inserted for sexual stimulation.
Yeah, because our lecture today is mainly on upper GI. Okay, the next thing that I wanted to touch on was removal of a coin using the Foley catheter method. There's a very neat little video clip that shows exactly how to do this. This typically occurs in kids, and they can be quite distressed and uncooperative, but it is possible to remove them without having to take them to theatre in the emergency department.
Okay, so this little guy ingested a coin and it's stuck in his esophagus. You can tell it's in the esophagus because it's transverse on the PA view, and on the lateral you see it on edge view. Now, to get the coin out, what we're going to do is pass a Foley catheter beyond the coin, blow the catheter up, and then pull back, and that will dislodge the coin up into the posterior pharynx. Now, when you're getting set to do this, one of the things you can do is fill the catheter with some barium and then pull it back out. And this will leave a thin stream in there, so that if there's any question of where the catheter is, you can take a quick x-ray and the Foley catheter will show up because of the lining of the barium that's in it. Now, the goal is to pass the tube through the mouth into the esophagus beyond the coin. And then once it's beyond the coin, you can estimate this by just holding it up to the patient. Roll the patient on their side, or at least get their head rotated to the side. Blow the catheter up, and generally in the range of 3 to 5 cc's is enough for a small child to get it out. A larger child, you may need a little bit more. Just pull it, you'll feel a little tug, and the coin will come out. Okay, so in this child, the child's been sedated lightly with propofol. You'll see him struggling a little bit, but that's because we're manipulating him. But if you leave him alone, he will fall asleep. You want him lightly sedated so they don't aspirate the coin when you remove it. Catheter is being passed through the mouth into the esophagus, and we estimated about how far it needs to go down. Once we believe we're past that point, we're going to inflate the balloon, and then we'll pull back. You'll notice that the child's rotated to the side and the head's rolled to the side. Now, what we didn't do was sweep the mouth after we pulled back on the balloon, which you always need to do, because sometimes the coin comes out without much resistance. And here's a surprise, we noticed that we did get the coin out. It's a pretty simple technique, and it works very well.
Yeah, I'm sure all of you guys know this technique and have possibly used it yourselves. If not, please actually try and do it. Get someone to teach you. Very useful method, and it prevents having to take a young child for a major anesthetic, general anesthetic in theatre, etc. As you can see, this procedure was done in the emergency department setting. Okay, this video is a fish spine.
80-year-old female patient was referred to us for the favor of evaluation of dysphagia. So as you can see here, our scope is sitting in the hypopharynx. I can see the vocal cords, and then gently introduce the scope in the upper esophagus. She's a known diabetic, so whenever patient has diabetes, we have to rule out fungal infection, a candida, which can lead to dysphagia. There is some evidence of mild fungal infection also. Here you can see some candidiasis. There is no doubt about it. So there is a partly some fungal infection here you can see on NBI in the upper esophagus. So this can add to her symptoms, number one. And let us find out if there is any other lesion in the esophagus because of her age. As we go down further, we are at almost 28-30 centimeters, and I see a sharp object stuck in the esophagus, and there is some pus coming out by the side of it. So looks like a fish bone has gone across the esophagus, and this is causing her dysphagia. So we need to take this fish bone out, and we will use a rat tooth forceps to gently push it out. We have to take care that it does not lacerate the esophageal wall. So first we will try and hold it gently and gently pull it out without crushing the. Let us see. So now we are going to open and we are going to gently hold it. Gently hold it. Open. Hold it. Hold it. Hold it. Yes. And now we have gently taken it out completely, and you can see that there is a very, very sharp fish bone. Yes, there is a long fish bone. Take it out. Take the picture of the fish bone outside. You can see the length of the fish bone. Clean the lens, please. Clean the lens, please. Completely. So you can see the length of the fish bone is almost 2 centimeters. So let us find out now anything further which causes her symptoms. We have to rule out. There is mild candidiasis, as we can see. So we will enter one more and inspect that area which is causing her symptoms. There's some laceration in the upper esophagus. And this is the area where we have removed it from. There is a small puncture site here, which is fine. We will go down. And now we are in the stomach. We will rotate to clockwise to go into the pipe.
Stop there. Yeah, that was quite a neat video that showed the removal of a sharp animal spine from the esophagus. Here, next area that we're going to touch on is the endoscopic management of bleeding peptic ulcer. Just a little bit of information. We know the Forest classification and the risk of rebleeding. We've got a 1A and B, spurting or oozing, and then there's a 2A and B where there's a non-bleeding visible vessel, NBVV, and 2B, which is an adherent clot. The 2C is actually listed here under 3, but it's usually listed as a 2C, is a flat spot, right, that you can see there, and type 3 is a clean base. So the type 3 has the least risk of rebleed, whereas the active spurting vessel has the highest risk of rebleed. This video clip is actually very neat. It shows you all the setup in a GI unit of all the different things that can be used for upper GI bleeding.
The next emergency is GI bleeding, right? That's the big one, the dreaded complication that we all hate. And we have a couple of tools to take care of bleeding. The first, I guess, we'll probably start with is just an injectable, right? The sclero needle. I think we have one here. So let's say you see a blood vessel that's bleeding, it's pumping a little bit. You know, oftentimes it requires more than one modality to stop the bleeding. So we might start by taking a needle and injecting epinephrine around the blood vessel to make it contract and stop bleeding. So basically, do we have a syringe? I don't know, we can show them how to hook up the syringe too. So,
one of these.
Yeah, so this is what the needle looks like. Basically, again, the mechanism is always the same. Okay, but basically you have a syringe filled with epinephrine. We attach it to the end of the sclera needle. Right, and then if you look, by grabbing it down here, right, if you push it in and out, see, we're just pushing it in, and you can see the needle
It's out.
coming out, right? And then to pull back, you just pull the needle back out. Right, so, and you can see the mechanism here. You slide the syringe in, slide it out, and that's how you bring the needle in and out.
We do
And then, yeah, once the needle, priming it.
priming it first.
But once the needle's out, we probably squirt you.
Sorry.
But anyway, so that's how you inject the epinephrine, right? So you put the needle out, and then you inject it. And again, it's all the same. I'll just show you what it looks like through the scope. Let me just clean this lens. I don't know why it's such a mess. I think we have gel on it. Okay. You can see the needle always looks a lot bigger when you're looking through the channel. Okay, so needle out. Okay, and you can see can we see it too? Let's see. Yeah, see the needle? Let me just jiggle it so you can get that little bubble off. So you can clearly see the needle as it's coming through. And then we push it up against the vessel, and we might say inject. And then then you grab the syringe, and you can come back over here just to show it the syringe. And then they just inject a cc of epi, or 2, whatever the GI guy feels they want to do. 1 cc, 2 cc, just inject it in, and that's it. And when you're done, the needle comes back, so you pull the whole syringe back, and then we just take it out. So that's the sclero needle. Okay. Another tool we have is the bicap. Why don't we do that one? Oh, which one is this? Oh, clip. Yeah, we love clips. Okay. Clips are the best. These are, so let's say we do the epinephrine, we slow down the bleed, and now we want to actually mechanically grab whatever's bleeding and just squeeze it shut. And with these clips, we can do that. So this is what a clip looks like. There you go, I'll give it to Nelda.
And this, everything will tell you. Like endoscopic hemoclip. Everything is named, and once the doctor say, you just have to look.
Okay. And a clip, well, why don't we show them how to work it before we put it in. So you don't want to squeeze it shut, right? If you squeeze it hard, you're going to deploy the clip. Once you deploy the clip, it's done. Yeah, it's going to be shot, and you can't do it again.
So all you need is to make sure that it's not open.
Yeah, but you can like gently sort of open and close, and you can see how it opens and closes. I'm gonna borrow this for a second. The nice thing about the clip is you can change just by turning. You know, I'm gonna open it just to show you. Let's say the vessel is tangential to the clip. So I want my clip to turn at an angle. All you do is you turn this, and if you just turn the clip, you can actually position the clip in any way you want so that you can deploy the clip the way you want to do it. Good, so then we close it. Okay, then I'll give that back to you. We pass the clip into the scope. Okay, and then let's say we say, okay, open the clip. Okay, so let's say I want to just turn it a little, change the angle. So why don't we turn it a little bit? See if we can angle it. Okay, then I put it up against, let's see, I'm going to pretend I'm going to clip something here. Okay, now why don't we close? So before you close, you can say, okay, I like that. I feel like I got the vessel. And then what can we deploy one there?
Yes.
Yeah, so let's just deploy it then. We'll let it go.
Then we just push your heart inside.
Yep.
And
that's
then
it.
the clip.
And now if you take a look, here's the clip on the tissue. And it's pretty good. You can't, that's not coming off. I mean, it'll eventually fall off. But that's it. That's how we deploy the clip. So once you push it all the way down, it releases the clip and you're done. If you misfire, you got to get another clip. So, but that happens. You know, what are we going to do? Expensive, but we try not to do that. Down to two things. We have the bicap.
Oh.
And then I'll do the banding at the end because that's usually the toughest. So bicap is when you want to add you want to put a heat, right? You want to use thermal cautery. You want to burn the area, push up against the vessel, and stop it. So I'll just let you know.
That's when we're going to use the. Remember, this on the bottom is just the irrigation system, and this is where we have the cauterization to burn. So it's also safe by cut. So.
Very easy to hook up, so nothing's hard. And sometimes for bleeders, we're using all of these modalities. You know, you got to put a clip on, it's still bleeding, then you want to burn it, and then you. So okay, so here I'll take this. Here's the tip, and you can see the little, sort of the coils on the end. That's what's going to burn the actual vessel. Yeah, soft coating.
Soft coat, 20 over here, unless the doctor, this is the level of the cauterization, right, that you're going to do.
Exactly. Yeah, so usually the setting is 20. Remember to hook this up to the right button.
And then
you want
the blue one has to be light on, and it has to say soft coat. This can be connected to the water, but most of the time we don't do it because the doctor can do it from.
Yeah, it's more of an older tool. The water used to go through here, but now we have the water going through the scope. So if we want to wash the blood away or whatever, we already have it hooked up through here. So really, that's it. That's how you hook that up.
So now then
And we have the pedals here. And then again, we take the device, just put it through, and you can see it coming through the tip of the scope. Okay, there it is. And then what we do is you find wherever you're going to treat, press it up against it, and then we just hit the button. But then we burn the vessel by stepping on the pedal. Very simple. That's the bicap. Easy enough. And so one more tool, which is the hardest of all, I think, to set up. Easy to use, very hard to set up. And that is the 6-shooter. Is this a new one, I think, or?
No, that's the same
That's
one.
what we use, okay.
Yeah, it's just some lead.
So this is when you have varicose bleeding, right? And nobody likes them. And I would say that I have a feeling a lot of the attendings when they come in, they may not know how to do this. They'll know how to use it, but they might not know how to set it up because they're coming from private practices. They're probably not going to see a ton of them. So this is why this is much important to particularly video this, so we can kind of review it. And it's very, very simple. But if you're not doing a lot of them, you just sort of forget it. Okay, let's see if I remember. Okay. So basically you have, this is kind of the dial, right? This is how you sort of shoot the bands, okay? And basically what we do is we take the device. This is the channel that we're putting all those little devices through. This is the channel here. We open it up and just put this in there, okay? This little, it's like a little diaphragm here, normally is not punctured yet. It's not able to pass anything through. So you take this little pin that comes in the kit and you put it through like that until you pop a hole, right? You just pop it open, take it out. Okay. Then you have this, it's kind of like a tool that just loads the string through the scope. They're both exactly the same on both sides. They have little hooks on both ends, right? Mm-hmm. So basically what you do is you take this, you just pass it through there, and just pass it till it comes out the end.
Through the hole we punctured.
Yep, right through the hole. And ultimately it's going to come through the end. Sometime. Okay, there it is. Now, pass it a little bit more. So now you have this end here, okay? Now we take the actual bander. This is what it looks like. I think this one's already been opened because we kind of used it to show how it works, but let me see, make sure I'm doing this one correctly too, because it looks like it's a little tampered with. Okay. So what we do then is we take this end here. Where's the other end? Here we go. Let me just put this end down for a minute. And then basically, as you can see, there's a little knot on the end. And this basically hooks. Actually, I'm going to pass the scope over to you now, if that's okay. We take this little knot, and it just goes into that little hook there. See that? Yeah, exactly. It just stays in. And then, now I'm going to switch with you. Now we pull it out, okay? So I'm going to drag the whole thing out through. And here comes the actual bander. Let's see. Okay, and then that just fits on the top.
Oh.
Okay?
Hold on, it's not
Yep. And then we take this off. Now we don't need this anymore. We've loaded. I'm going to put that off to the side here.
You screw that on, or it just...
You just kind of push it on. You don't have to go too tight.
Okay.
And then, if you look over here, see, depending on how you have the dial, it like in this case, it's going in one direction. If I pull it back, now it only goes in the other direction. It doesn't matter, whatever you're comfortable with. There's a little slit here. You basically pop this into this slit, and I'm not putting it down, so it's hard to. I'm just gonna shift my hands here. So that goes into that little slit like that, and then you just kind of roll it up. Let me make sure so it rolls nice and tight. Yep, exactly right. Roll it up, and now once you feel a little tension, now we're ready. So that's what you're seeing through the scope. You have your bander, and basically then I want to, find my barracks. Again, the GI, most of them know how to do this. You find the vein you wanna band. They put it on that little vessel and then suction it. So the vein sort of gets pulled into the channel. And then once it's on, you deploy a band. That's how you do it. You literally just twist the dial,
And this is what
and it shoots a little
goes
rubber
on
band.
there? Oh,
Yep.
okay.
And you can see it's pretty small once it's in, but that's going to grab the barracks, and it's going to choke it off. But if you put something in, I don't know, like let's say this is the vein. So if you put it, let's say, so you suction the vein so that it's in the channel. If I could just ask you to hold that there. Like, make sure it's in there, because the job of the GI guy is to actually suction it in. Okay, good. And now if I deploy the next band, wait, I'm turning the wrong one. That's why. Here we go. Ready? That's it. It stays on the.
That's how it's going to take that.
And how many bands are in that?
It's a 6-shooter, so there's 6.
Oh.
Yep. And that is it. So that's really the last of the tools. So just to summarize then, 2 emergencies really, very simple. Foreign body, right? We talked about the overtube We talked about the grabbers, basket, snare. These are all the devices that we can pass in and out through the overtube to pull out whatever we're trying to get. That's the foreign body. And then for bleeders, we have, particularly for varicose bleeders, the 6-shooter. And then for ulcers and other bleeding things, we've got the scleroneedle to inject, bicap, cautery, and the clip. And I think that's it, right? I think we got it all.
Yeah.
So, great, and that's everything.
Okay, so that was a neat video which actually focuses on the setup in the GI unit as opposed to actual endoscopic pictures, which I thought was very useful because a lot of the time you don't get an opportunity to see this. So this video explains everything very clearly, high definition video. You can actually see all the different components and different things. Just one question that I had during the video was that shouldn't the adrenaline be diluted? Obviously, the doctor here mentions adrenaline, he just says adrenaline, but you saw that it was in like a 10 ml syringe. So you know that adrenaline comes in a 1 milligram per ml size. So that has to be diluted. The dilutions that you can use, you can put 1 ml into 10 mls of saline, making it a 1 in 10,000. You can also put 1 ml into 200 mils, making it a 1 in 20,000, or into a liter, making it a 1 in 100,000. So the current teaching is that it doesn't actually matter whether or not you put adrenaline into the solution. You can actually just inject saline. And the reason behind it is that it's not so much the effect of the adrenaline, but it's the injection of fluid into the surrounding mucosa, which tenses the area and can actually compress the vessel. Having said that, I personally still use a little bit of adrenaline because it seems to make sense. But apparently the theory is that just normal saline will work as well as adrenaline. And this is actually being tested in studies. Any other questions, please post. Okay, this is the little bit of information about the thermal probe. In South Africa, we have a thing called a gold probe. It actually has a little bit of gold in the tip, and it is a bipolar device. They had a different brand in the video, and the idea is that you can actually apply that directly to the bleeding vessel and compress it, and then apply bipolar diathermy energy and ablate that bleeder altogether. With bleeding vessels, like the doctor said, it's a combination of sclerotherapy, heated probe therapy, clips. There's even an over the scope clip, OTSC, which we may not have a chance to look at today, but I'll definitely show it to you next week. And you also have the banding, which is not used for ulcers, but it's used for bleeding varices. Okay, this is just a little bit of information about clips being applied to a vessel. Now, when you look at this with an endoscope, despite the high definition, you're not going to be able to see the direction of the vessel, which makes it a little bit difficult. Now, there is a technology that is available. I haven't seen it in South Africa, but it is available in the first world. And this is where you actually use a Doppler endoscopic probe. It fits down the biopsy channel, and it actually gives you a Doppler signal similar to the handheld Doppler that you may have seen used by the vascular surgeons to assess pedal pulse or radial pulse, for example. So I've got a little video on this, just more out of interest's sake. It's just a brief 2-minute video, but just to give you some understanding, just bearing in mind that well, I haven't seen it anywhere in KZN. Perhaps some of you guys might have seen it in private practice or in one of the other centers.
The VTI endoscopic Doppler system allows physicians to deal with rebleeding before it occurs. Two lesions are seen in the duodenum. The first is a flat pigmented lesion, and the second is a larger clean-based ulcer. The VTI endoscopic Doppler probe is used to evaluate both lesions. The clean-based ulcer is found to be Doppler negative. The flat pigmented lesion, however, has a distinct arterial signal at the 5 o'clock position. Based on the patient's clinical condition and the positive Doppler signal, a decision is made to treat this lesion endoscopically. First, multiple epinephrine injections are targeted at the Doppler positive region. The final injection incidentally provokes bleeding from the site, providing correlation between the Doppler positive signal and the vessel that lies below. Next, a heater probe is applied to the ulcer. The Doppler probe is used again after application of endoscopic treatment. The ulcer is now Doppler negative. This patient did not experience a recurrent ulcer bleed.
Okay, that was quite a neat video. So we've run out of time. Basically, we've covered esophageal dilatation and stenting, the removal of foreign bodies, endoscopic treatment of bleeding peptic ulcer, and a very nice video on the setup. The video on over-the-scope clip, also known as a VESCO, then the endoscopic treatment of bleeding esophageal varices, POEM, and corrosive injury of the upper GIT we'll look at next week. Just to remind you guys that there are OSCE questions that I've put up. If any of you guys have difficulty seeing these or accessing them, please just let me know. Just want to try and show you quickly.